Welcome to the 2020-2021 Medical Dental Legal Update, a 20-hour program on medical malpractice, risk management, healthcare law, practice management, and selected clinical topics. The following presentation, Preventive Cardiology and Lifestyle Medicine Update, features Barry A. Franklin, Ph.D. Dr. Franklin of Royal Oak, Michigan, serves as Director of Preventive Cardiology and Cardiac Rehabilitation at Beaumont Health, as well as Professor of Internal Medicine at Oakland University William Beaumont School of Medicine. He is past president of both American Association of Cardiovascular and Pulmonary Rehabilitation and American College of Sports Medicine, and serves on the editorial boards of 16 scientific and clinical journals. Dr. Franklin has written or edited more than 700 scientific and clinical publications, including 26 books, and has given over 1,000 invited presentations worldwide. In 2015, he was listed among the world's most influential scientific minds. You may contact Dr. Franklin with your questions or comments at barry.franklin@beaumont.edu.
Hi, I'm Barry Franklin. I direct the Preventive Cardiology Program and Cardiac Rehab Program at William Beaumont Hospital, Royal Oak, Michigan, where I've been for the last 35 years. On a day-to-day basis, my focus is really on preventive cardiology, cardiac rehabilitation, and lifestyle medicine. And I prepared this talk to address the common questions I get from patients as well as primary care physicians in terms of what's hot in the area, what do I need to know. I want to open up with this classic report from a pretty darn good program as well, the Cleveland Clinic, published in the early 2000s, in which they looked at a large number of people in their database using a technique called intravascular ultrasound. And what they found was astounding. They found that about 85% of all individuals in their database over the age of 50 had atherosclerotic cardiovascular disease. So a good friend and colleague who recently passed away, Marty Grace, a cardiologist who was a cardiologist in Chicago, said, for me, the question isn't whether middle-aged or older adults have heart disease. They probably do. In fact, I can look at a guy 55, 60, 65 and say, I'm 85% confident you got heart disease. The critical question is, how do you prevent acute cardiovascular events, catastrophic events, the kind of events, as you see in this next slide, that killed the beloved newscaster, Tim Russert, at the age of 58, or the fine actor, James Gandolfini, at the age of 51. This population cohort who is most susceptible to what we call SCD, sudden cardiac death, unfortunately is men, 60 years of age, plus or minus 5. Every year, we get more than 300,000 sudden cardiac deaths in the United States. More than 850 Americans die each day due to sudden cardiac death due to underlying atherosclerotic cardiovascular disease. When we look at total numbers, it's over 800,000 people in our country die every year of atherosclerotic cardiovascular disease. Worldwide, it's 17.3 million, making it one of the biggest societal killers. So the question that we pose today is, what can we do? What can you do as a primary care doc? Seeing patients, helping those patients help themselves, their family members. Avoid being among these fatalities each year. This next schematic is really telling. It was developed by Darius Mozaffarian, who was at Harvard at the time, and it's very simple. I oftentimes show it to patients. And it highlights what he refers to as a triangle for cardiovascular disease. And at the bottom of that triangle, the foundational factors are 3: poor dietary habits, physical inactivity, and cigarette smoking. And you can see that those lifestyle habits, poor lifestyle habits, lead to a host of novel and established risk factors, including diabetes, obesity, high cholesterol, hypertension. And those, over time, lead to inflammation of the arteries, early vascular disease, and finally the clinical endpoints that you see in that slide: coronary disease, abnormal heart rhythms, heart failure, stroke, cognitive decline, and ultimately death. If you look at that slide, there's a small coronary artery in my upper right-hand corner there, and that's a coronary artery, for your information, of a 36-year-old woman who unfortunately died of a massive MI. For this lecture, I'm going to focus to a large extent on those foundational factors. That is, poor dietary habits, physical inactivity, and cigarette smoking, and secondhand smoke, which I think you'll find absolutely astounding, some of the stuff I'll tell you. So I'm going to focus on those things. I'll also touch on the latest in terms of pharmacotherapies. What kind of drugs are beneficial in terms of preventing initial and recurrent heart attacks? And lastly, genetics. People say, "Bees, I picked the wrong parents," or "My dad had a heart attack early. Does that mean I'm destined to it?" And we'll cover all those topics over the next 50 minutes. We'll cover 5 topics. First topic, as you see here in this slide, is the hazards of cigarette smoking and secondhand smoke. Let me preface my remarks by saying the single most important factor, in my humble opinion, that I could give anybody is if they're a cigarette smoker to stop, and ideally stop before the age of 40. These were classic media coverage of cigarette smoking. And if you look here, you'll see some famous actors. You can clearly see Robert Mitchum and Ronald Reagan were also used in many TV commercials promoting cigarette smoking. And one of the early emphasis was they got doctors behind cigarette smoking. More doctors smoke Camels than any other cigarette, just what the doctor ordered. Viceroys filter the smoke. This 1960s and 70s was what the American public was bombarded with. What you see in this next figure is a very, very classic painting by Frank Netter, one of the most famous artists in the world. And Frank Netter shows a patient walking out of an upper-end restaurant, walking up steps, going outside in the cold air, climbing those steps, carrying a heavy briefcase, and he's suddenly clutching his chest because he's experiencing angina after that heavy meal. And if you look real closely at that slide right here, and I put a circle around it, you see he's just dropped his cigarette. Early in my career, I clipped this out of the newspaper. Marlboro. I grew up watching the Marlboro Man. Sexy. Marlboro Man, obituary. Wayne McLaren died at the age of 51 of lung cancer. Smoked for 25, 30 years, 1 to 2 packs a day. He said it's simply not worth it. He went on an anti-smoking crusade the final years of his life. How dangerous is it? I've been showing this slide for years. Guy goes to a fortune teller, there's a big sign, discounts for smokers. Patient says, "Why do you give discounts?" The fortune teller said, "Well, we give discounts because there's a lot less to tell." Fact of the matter is, on average, there's 10 to 12 years less to tell. This classic report appeared in the British Medical Journal 2004. Richard Dahl and colleagues looked at 34,000 male British physicians, cigarette smokers versus non-smokers, looked at morbidity, mortality. Beautiful follow-up on this study. What did he find? What he found is shown in this graph. And the take-home message is if you compare cigarette smokers and non-smokers, all comers, on average, there's a 10-year difference in lifespan. That's the bad news. The good news is if you stop before, and I've circled it here, the age of 40, there's hardly any penalty as a result of the cigarette smoking. My answer is don't wait to 39 or 39 and a half. Stop at 30, stop at 35. But to a large extent, the sooner you stop, the better the long-term prognosis. Some people looked at this and said, it's hard to believe. Is it really 10-year deficit? A subsequent study confirmed that, published in the prestigious New England Journal of Medicine. Let me set the stage for you. This was the U.S. National Health Interview Survey. 113,000 women, 89,000 men studied for a long period of time, looking at smokers versus non-smokers. What did they find? Same finding. Life expectancy was shortened 11 to 12 years among current smokers as compared with those who had never smoked. And once again, people who stopped before the age of 40 reduced the risk of death associated with continued smoking by about 90%. What about secondhand smoke? I'm in meetings all the time where one employee says, well, I have a right to smoke, and another employee says, well, I got a right to breathe clean air. What's the take-home message? The take-home message is this, from this researcher and this scientist. You study thousands of people like I do. What you find is that secondhand smoke increases the risk of coronary disease and cardiac events by 30%. All other factors equal. So if you live with a smoker and you're breathing that person's smoke, all other factors equal, you're at 30% greater risk of experiencing a cardiac event. If you work in a bar and that bar had smoking, you're breathing somebody else's smoke. There's no question in my mind. Cigarette smoking, breathing somebody else's smoke, damages your arteries and increases the risk of a coronary event by 30%. Look at this classic study by Pell and colleagues, published in New England Journal of Medicine 2008. In Scotland that year, they decided no smoking more in public places. Since the end of March 2006, smoking has been prohibited throughout all public places in Scotland. Did they notice anything? Overall, the number of admissions for acute coronary syndrome, that's heart attacks, angina, decreased by 17% the next year. 17% as compared with a 4% reduction in England and a 3 to 9% reduction over the last decade in Scotland during the previous decade. So there's no question whatsoever that simply adopting a public ban on smoking reduces the number of heart attacks in that area. If you say to me, Barry, I still don't believe it, do you have any other data? Yeah, look at this graph. Before legislation, 2005, 2006, after legislation, in every month, there were fewer heart attacks in the Scotland area. This is a fascinating report done by a colleague, Stan Glanz, published in the prestigious journal Circulation, 2013. City in Colorado, Gilpin County, Colorado. Very famous place that has a large casino presence. The people who run Gilpin County, Colorado decided years ago, we're gonna have a smoking ban. But they didn't have the nerve to do it all throughout the city. We'll do it every place except the casinos. What happened? Initial implementation of the smoke-free law, which exempted casinos, was followed by a 23% drop in ambulance calls from locations other than casinos. No significant change from casinos. Not surprisingly, they didn't have a smoking ban. The evidence was so compelling that they decided 2 years later, we got to extend the smoking ban to casinos. What happened? Law requiring smoke-free casinos taken into effect was followed by a 19% drop in ambulance calls from casinos, but no change in calls outside casinos. There is no question whatsoever that by having cleaner air, there are fewer heart attacks provoked in populations. That's why I tell people, vote for Clean Air Acts, vote for smoking bans. If you still don't believe it, look at this next slide. Bremen, Germany. They did a smoking ban in all public places. What did they find? They saw as soon as they implemented that smoking ban, which you see on that slide, there was a decrease, total number of major heart attacks called STEMIs, and most of that decrease, in fact, almost all of that decrease was in non-smokers. They concluded that by saying these results may be explained by the protection of non-smokers from passive smoking and the absence of such an effect by the dominant effect of regular smoking in active smokers. Topic number 2 of the 5, cardioprotective medications. What do you need to know here? These are the 4 major medications that reduce the likelihood of acute coronary events: aspirin, cholesterol-lowering statins, beta blockers, and ACE inhibitors. If you study these medications like I do and read the reports, each medication on its own, on average, decreases the risk of an initial or recurrent cardiovascular event by 18 to 44%, an average being about 23%. This report from legendary cardiovascular program Duke University came to the sobering conclusion that 30% of their patients who were prescribed aspirin, statins, beta blockers weren't taking them. Although the doctors thought they were taking them, they found out that many of these patients, for one reason or another, adverse symptoms, cost, etc., were not taking these medications. And this report by Ho and colleagues clearly showed that patients who are prescribed these medications, who are not taking them, are typically a 50 to 85% greater risk of having recurrent cardiovascular events. This is a scary kind of slide published years ago by a good friend and colleague, Dr. Bill Roberts, editor of American Journal of Cardiology. What you see on the left-hand side is a 37-year-old patient in his clinic who developed large, almost like cysts, throughout his body. And those cysts were what are called xanthomas. They were cholesterol deposits. He had a cholesterol level well over 500. There was a genetic predisposition for cholesterol abnormality. This guy, at the age of 37, had had 3 previous heart attacks. So Roberts was one of the first people to say, wow, cholesterol does play a role in this disease. And when we see extreme hypercholesterolemia, it can lead to malignant atherosclerosis, xanthomas, as evidenced by xanthomas, sometimes even small yellow streaks under the eyes. A big proponent of cholesterol-lowering medications, Roberts highlighted the fact that regardless of the statin, if you look at the dose, which can be variable, total cholesterol typically decreases 22 to 47%. LDL, the lousy cholesterol, decreases 27 to 60%, and HDL, a small bump of about 7%. One of the most recent studies was the Heart Outcomes Prevention, or HOPE-3 trial, published in the New England Journal of Medicine, April 2016. They looked, as you see in this slide, at 4 outcomes, including stroke, heart attack, and the need for coronary revascularization. One group took rosuvastatin, a cholesterol-lowering agent, the other a look-alike placebo pill. They followed these patients over a 7-year period of time. What do you see here? The mean overall LDL cholesterol was about 27% lower in the rosuvastatin group than in the placebo group, but more importantly, those adverse cardiovascular outcomes were 25 to 37% lower in the rosuvastatin group. So there's no question in my mind, this is one of many studies, that cholesterol-lowering statins do reduce the risk of future coronary events. This was considered an intermediate risk, ethnically diverse population who did not have known cardiovascular disease. When I see people who've had heart attacks on a day-to-day basis, at least in our hospital, but I believe throughout the country, the standard of care now is to at least try what are called high-intensity statins. The 2 most powerful are rosuvastatin and atorvastatin. Rosuvastatin at a dose of 20 or 40, atorvastatin at a dose of 40 or 80. And here you can clearly see in this recent report in the JAMA Cardiology, the high-intensity statin group had the lowest subsequent mortality. There's a new agent on the market now as well called PCSK9 inhibitors. Some preliminary studies are shown in this slide. The one on the left basically showed if you look at LDL cholesterol with statin and then you superimpose the PCSK9 inhibitor lowered the LDL an additional 52 to 61%. So clearly very, very strong. And if you look here, the mortality is about half that not receiving the PCSK9 inhibitor. So a recent advance are these PCSK9 inhibitors. The downside, the major downside, is these drugs are very expensive and doctors have to justify to the insurance carrier why the patient needs PCSK9. In other words, they've tried this statin, they've tried that statin, and they didn't work. I get the question all the time with drug therapy. How low should my heart rate get? How low should my blood pressure get? In general, if you're sitting in my office and you say, what should be my goal? My answer is, in general, lower is better for both heart rate and blood pressure. In this classic report, which looked at post-MI patients, people who've had heart attacks, they looked at patients who were taking beta blockers. And what did they find? They found, in general, for heart attack patients taking beta blockers, the lower the resting heart rate, the better the prognosis. So each 10-beat reduction in the resting heart rate reduced the relative risk of cardiac death by about 30%. So if I see a patient whose resting heart rate is 80, 85, my goal is to work with a referring physician and get that resting heart rate down to 50, 55. In general, a slower resting heart rate means a longer life. Studies have shown that men and women with resting heart rates below 60 have far fewer cardiac events than men and women who have faster resting heart rates, that is 80 beats or more. How about blood pressure? For many years, I told patients, incorrectly, unfortunately, that 140 over 80 or 90 is a good blood pressure. I was wrong. The SPRINT trial, published in New England Journal of Medicine 2015, clearly showed if we take over 9,000 patients with elevated systolic blood pressure and randomize them to blood pressure lowering medications designed to get the blood pressure either under 140 or under 120, the more aggressive approach works better. That is, getting the blood pressure under 120. This intervention was in fact so compelling that it was stopped early after 3.26 years due to the fact that those who were targeted to get their blood pressure below 120 had 25% fewer acute coronary events, as you see on this slide. So standard treatment, blood pressure around 130, 135, versus aggressive treatment, intensive treatment, blood pressure around the 120 or lower, and you can see on the right-hand side, the intensive treatment was associated with about a 25% lower mortality. So lower blood pressure, lower heart rates. When patients ask me to summarize, ideally I want to see your resting heart rate 60 or below. I want to see your blood pressure 120 over 80 or below. Topic number 3, evidence-based dietary strategies. What do you need to know here? One of my favorite quotes, Bill Roberts, editor of American Journal of Cardiology, was way ahead of the field. His famous quote, done 30, 35 years ago, is that our excessive intake of meat is killing us. We fatten our cows and pigs, we kill them, we eat them, and then they kill us. How sobering. This classic report, published a few years ago in the Archives of Internal Medicine, combined data from the Harvard Health Professional Study, the Harvard Nurses Health Study, followed patients for more than 3 million person years, looking at dietary intake. What did they find? They concluded this was the first large prospective scale study showing that consumption of both processed and unprocessed red meats is associated with an increased risk of mortality from cardiovascular disease and cancer. This study also got worldwide attention, published in the New England Journal of Medicine. It's a diet that I personally follow called the Mediterranean diet. Mediterranean diet allows fish, chicken, a little bit of wine, vegetables, and so on and so forth. What did they find? Among persons at high cardiovascular risk at a number of centers in Spain, the Mediterranean diet supplemented with extra virgin olive oil or mixed nuts reduced the incidence of cardiovascular events, as you see here in this slide, by about 30%. This slide looking at vegetarians versus non-vegetarians from the EPIC-Oxford cohort study showed even after adjusting for confounding variables, vegetarians had a 32% lower risk of ischemic heart disease than did non-vegetarians, even after adjusting for BMI, as well as age, smoking status, and other ischemic heart disease risk factors. Trans fatty acids can also adversely affect coronary disease. Trans fatty acids typically found in fried foods, commercial baked goods, processed foods, and margarine. We now know that trans fatty acids have abnormal impact on LDL and HDL cholesterol levels, Lp(a) and triglycerides, indices of vascular inflammation, including CRP and interleukin-6, and that they increase coronary disease and the risk of diabetes. How much trans fats should you eat per day? The point I want to make here is that zero is not zero. In fact, the government, the Food and Drug Administration, allows manufacturers to put zero trans fats. This food contains zero trans fats if it contains less than 0.5 grams per serving. I study this stuff for a living. As I look at the small print on a lot of these products, they have between 0.41 and 0.49 grams of trans fats per serving. Very, very small, but nevertheless multiples of those servings, even though people are being misled by saying zero trans fats, can be problematic. AHA recommends less than 1% of your calories be trans fats. That means if you consume 2,000 calories a day, no more than 20 of those calories should come from trans fats. What do I tell patients? Here's a simple way to determine it. Don't believe the label says zero trans fats. Look at the label, however, and if you see the word hydrogenated or partially hydrogenated, there's trans fats in that food. Stay away from it. How about sodium? Be aware of these 6 salty foods, which are very, very high in sodium, as you see in this slide. Cold cuts, cured meats, breads and rolls, pizza, sandwiches, soup, and poultry. I remember years ago, was asked first about Campbell's soup. How healthy is it? Patient said to me, there's no saturated fat, there's no trans fat, it's only 100 calories. That sounds like a winner. Take a look at the milligrams of salt. The original Campbell's soup had 770 milligrams of salt per serving versus 100 calories. I tell patients, remember the 1-in-1 rule. Remember the 1-in-1 rule. Look at the milligrams of salt and look at the calories per serving. If that number is about the same, it's generally a good food. My wife bought some Kashi cereal the other day, so I put it to the test. Kashi cereal, 130 calories, 120 milligrams of salt. It's a damn good food. What's a bad food? Some of the lean cuisine dinners, some of the Weight Watcher dinners that says have 220 calories, look at the milligrams of salt, 6, 7, 800, 900 milligrams of salt. So in general, remember the 1-in-1 rule. Look at the calories per serving, look at the milligrams of salt. Ideally, it should be 1-in-1. So to summarize, this recent article in the Journal of American College of Cardiology says, tell patients, eat more fruits, veggies, whole grains, nuts, legumes, beans, and seafood. It's as simple as that. Remember a local talking about white bread? She said years ago, the whiter the bread, the sooner you're dead. I tell patients that. Stay away from processed meats, refined grains, sugar-sweetened beverages, added sugar, trans fats, high sodium foods, foods high in saturated fat. Topic number 4. What do you need to know in terms of exercise? And the latest on exercise, physical activity, and high-intensity interval training. This was a classic study published in the prestigious New England Journal of Medicine, 1998. They looked at over 707 non-smoking retired men, 61 to 81 years of age. They looked at the distance walked per day. 12-year follow-up. What did they find? Over 200 deaths in these men. But what they found was astounding. What they found was men who walked less than a mile a day had twice the mortality rate as those who walked 2 miles or more a day. Regular walking, they concluded, associated with a lower overall mortality rate in older, physically capable men. You don't believe the data? Here's the graph actually showing the highest total mortality in men who walked less than a mile a day, the lowest mortality in men who walked 2.1 or more miles per day. Something else that I tell patients that I think a lot of physicians don't realize, that 2 miles does not have to be done all at one time. I tell patients the effects of exercise are cumulative. In other words, you don't have to put the dollar bill in the big piggy bank all at one time. You can put 4 quarters in there. You don't have to do 2 miles or 2.5 miles. Do a half mile, do a mile. All this stuff adds up. The effects of exercise are cumulative. How about walking speed? This study from New Zealand looked at walking speed in older men and came to a startling revelation. Older men who walked at less than 2 miles per hour in day-to-day activities had the highest mortality. Anything above 2 miles an hour, the mortality decreased. And interestingly enough, older men in their 60s, 70s, and 80s who walked at 3 miles an hour or faster had 0 mortality over a 6-year follow-up period. Very, very interesting. Why is that? When people ask me, why is that? I believe it's this. If I got an older guy who's 70 years of age, who walks at a 3 mile per hour pace, I know that older man, if he's walking day to day at 3 mile per hour pace, he's working at what we call 3.3 to 3.5 METs. I know if I do a treadmill test on that older guy, he's going to be above 5 METs. And as I mentioned previously, 5 METs is the cutoff. You want older people to be above a 5 MET capacity. So I tell people, disguise your exercise. In other words, you don't have to necessarily go to the gym. While you're out walking, pick up your pace above 3 miles an hour, you're actually getting a workout in. Look at this slide. It's from the famous Heart and Soul study. 556 outpatients with stable coronary disease. They ask all these patients, walk 6 minutes as fast and as far as you can. They did an 8-year follow-up. Look at this graph. What you see is pretty amazing. Quartile 1, those who covered the least distance in red, had the highest rates of subsequent heart failure, myocardial infarction, death in any event. And quartile 4, those who covered the most distance, had the lowest rates of heart failure, myocardial infarction, death in any event. Simply walking speed is a very strong prognostic indicator. What about METs and understanding METs? I get this question all the time. As you're sitting there listening to me, or as I'm speaking right now, we're at what we call 1 MET. That's 1 unit of oxygen, 1 unit of energy expenditure. If I take you and put you on our treadmill at Beaumont, we gradually increase the grade and speed till you can't go any further. Most adults are 6 to 10 METs. What does that mean? It means most adults can increase their energy expenditure 6 to 10 times above rest. Heart failure patients, many obese patients, are in the 2 to 5 MET range. In contrast, endurance athletes we sometimes see are in the 20 to 25 MET range, which means they can increase their energy expenditure 20 to 25-fold. What's important for you to recognize is that each 1 MET increase in fitness transforms to about a 15% reduction in mortality. That's very, very important because I oftentimes say to the fellows and residents at the hospital, how many of you guys for heart health recommend aspirin? And people raise their hands. How many recommend beta blockers? How many recommend statins? How many recommend regular exercise? Far fewer. Yet, aspirin, statins, beta blockers typically reduce mortality by about 23%. 1 MET increase reduces mortality by 15%. The ideal combination is exercise regularly, take your prescribed medications. The best test for determining your MET capacity is a treadmill test. And next time you have a treadmill test, when you leave, the first question you should ask the doctor or the technician who supervised it is, how many METs did I get up to? If you're less than 5, you're at a much higher risk group. If you're over 10 METs, you're at a much lower risk group. In general, as we discussed previously, this slide shows the higher the METs, the higher the fitness, the better the overall prognosis. This is dividing fitness into quintiles. So 1 is the bottom, the least fit, 5 is the most fit. What's interesting is that the person who gets the most benefit out of an exercise training program is not the person who goes from quintile 4 to quintile 5, but goes from quintile 1 to quintile 2. Horrible fitness to below average fitness, as you see here, conveys the greatest subsequent reduction in mortality. So getting out of that 5 MET exercise capacity, who gets the most benefit? Anything over 10 METs, as you see in this next slide. So 10 METs or higher conveys the best overall prognosis. Once again, I'll agree, the 12 or 13 MET guy will beat the 10 or 11 MET guy in a race, but in terms of long-term benefits and survival, 14 METs versus 10 or 11 METs is about the same in terms of long-term prognosis. It's an article we published a few years ago in JAMA, where the editors of JAMA asked Bill Bowden, Annette Wenger, and myself, what do primary care physicians have to know? If you say to me, Barry, give me the take-home message in that JAMA article, it's this. Each 1 MET increase in patients with stable ischemic heart disease is associated with about a 16% reduction in mortality, which, as I alluded to moments ago, confers about the same benefit that you find from low-dose aspirin, statins, beta blockers, and ACE inhibitors after acute myocardial infarction or heart attack. I oftentimes ask patients, if there were a pill that you could take to cut your risk of dying in half over the next 30 years, would you take it? There is such a pill. It's called regular exercise or physical activity. This was a classic report published in Circulation, Cardio Quality Outcomes 2014 from the Cooper Clinic, Dallas, Texas. Look at these data. They looked at a large cohort of men, a large cohort of women who had varying risk factor profiles, as you see here, but they further divided those cohorts according to risk factor profile by low fit and high fit. And what you see is, regardless of the risk factor profile, low fit men and women have about twice the mortality rate. This is a paper we published just last year. I get the question all the time. The major reason older people are hospitalized is what's known as congestive heart failure. It's a paper we published with Peter Kokonos using the VA database, looking at cardiorespiratory fitness, body mass index, and the incidence of heart failure. This was assessed in 20,000 US male veterans, average age 58, who completed a maximal treadmill test and then were followed over the next 13.4 years. All had no evidence of ischemic heart disease or congestive heart failure. They were classified based on their peak MET capacity as least fit, low fit, moderate fit, or high fit, and according to their body mass index, normal, overweight, or obese. As I alluded to, over 13-year follow-up, there were almost 3,000 heart failure episodes. What did they find? In a nutshell, increased cardiorespiratory fitness was associated with progressively lower heart failure risk, regardless of the BMI, suggesting that heart failure risk associated with obesity can be favorably modified by improving your cardiorespiratory fitness. Look at these data, published in the European Heart Failure Journal, 2019. Here you see we divided the population into 3 groups: BMI less than 25, normal weight; BMI 25 to 29.9, overweight; and BMI over 30, which means obese. Then we further subdivided into high fit, moderate fit, low fit, and least fit. What do you see? Regardless of the BMI, those individuals who were least fit were 2.5 to almost 3.5 times more likely to develop heart failure in the subsequent years. So the take-home message for the 45 and 50 and 60-year-olds we see is get active now, and you markedly reduce your risk of developing heart failure later on. Exercise also, we recognize, increases the risk of atrial fibrillation, a heart rhythm irregularity associated with transient ischemic attacks and strokes. It also increases the likelihood of coronary calcium, and this study by researchers at the Cooper Clinic looked at both coronary calcium and cardiorespiratory fitness in over 8,000 men who had no evidence of coronary artery disease. Over an 8-year follow-up, there were 383 cardiovascular events, and basically what they found is the higher the coronary calcium, the greater the likelihood of a coronary event, but regardless of what the coronary calcium was, each additional MET increase in fitness, there was an 11% lower risk for cardiovascular events. So basically the conclusion is, at any level of coronary calcium, it pays to be physically active or physically fit. And here you see on the right-hand side, cardiorespiratory fitness hazard ratio 0.89, indicating that an 11% reduction in subsequent coronary events. As we move on then and conclude this section, recognize then that extreme exercise may in fact slightly increase coronary calcium in endurance athletes. That said, coronary calcium levels, if they're higher in endurance athletes, are associated with a higher rate of cardiac events as opposed to athletes who don't have coronary calcium. On the other hand, the risk overall for cardiovascular events is lower in physically active individuals compared to their inactive counterparts with the same coronary artery calcium score. These results provide reassurance that highly active individuals with coronary calcium can oftentimes continue their exercise programs provided they remain asymptomatic. This slide basically summarizes then the extreme exercise hypothesis. A number of studies now suggesting that those individuals involved in high volume, high intensity exercise regimens oftentimes show slightly higher coronary calcium scores and are at greater risk of developing atrial fibrillation, which is associated with transient ischemic attacks and stroke. Another very, very hot topic that I'm bombarded by patients and primary care physicians is what's called high-intensity interval training. This slide shows the typical training pattern for continuous or steady state versus high-intensity interval training. The classic study was done in 2007 in the journal Circulation by Dr. Wisloff and colleagues, in which they looked at heart failure patients. Heart failure patients whose average ejection fraction was 29%, heart failure patients whose average fitness was just 4 METs and who were being medically managed. And they randomized them to 3 groups: a control group, a moderate intensity exercise group, or high intensity interval training. Basically, as you look at this next slide, a comparison of endothelial function versus maximal oxygen uptake. As expected, the control group showed no favorable changes in endothelial function or maximal oxygen uptake. Moderate continuous training showed nice improvements in endothelial function and VO2 max. On the other hand, the high-intensity aerobic interval training showed the greatest improvements in endothelial function and maximal oxygen uptake. They concluded that high-intensity interval training may be a reasonable alternative for very rapid changes and improvements in people with coronary disease. This study by Louis and colleagues looked at a number of studies comparing high-intensity interval training versus moderate continuous training. And basically what they found is that yes, high-intensity interval training is superior in terms of improving maximal oxygen uptake. On average, the improvement, as you see in this slide, is about 1.8 milliliters of oxygen per kilogram per minute higher in those who engaged in high-intensity interval training. That's about half a MET. On the other hand, they pointed out that resting heart rate showed greater reductions in moderate continuous training, as did body weight. So there was a bit of what they call a trade-off. There's also good evidence, however, that high-intensity interval training, according to this report, is associated with a greater incidence of cardiovascular events. In this particular report, published in Circulation, 1 cardiac event every 23,000 hours of participation for high-intensity training in contrast to one cardiac event every 129,000 hours, about 6 times higher in the high-intensity interval training group. It's a paper we published last year, American Journal of Cardiology, which we looked at the benefits and risks of high-intensity training in patients with coronary artery disease. We concluded that high-intensity training elicits slightly greater improvements in aerobic fitness, about half a MET. On the other hand, we expressed some reservation in that patients with known or suspected coronary disease should be very, very cautiously prescribed high-intensity training, especially outside of medical environments where complications could occur. Last topic today is genetics versus healthy lifestyle and factors that affect life expectancy. I want to summarize 2 major blockbuster reports in closing this presentation. This report was by Kara and colleagues, published in the prestigious New England Journal of Medicine. I jumped at this when I saw it because I'm oftentimes confronted by patients who said, my destiny is a bad one, I picked the wrong parents, and I'm destined to early premature death and coronary disease. They addressed the question, can bad genes be offset by a healthy lifestyle? And in this study, they looked at 4 large-scale studies, including extensive genetic and lifestyle information. They followed over 55,000 adults for 20 years. So they had genetic information, lifestyle information, 4 different studies, 55,000 adults, 20 years. So these are powerful data. How did they categorize genetics and lifestyle? As you see in this next slide, they had a genetic risk score. They looked at all the genetic materials and they categorized them based on if they carried any of the 50 gene variants associated with heart disease into these patients are low, intermediate, or high risk. Then they looked at their lifestyles and established 4 factors that they looked at. No current smoking, no obesity, that is BMI less than 30, healthy diet, and regular physical activity. They considered a favorable lifestyle as 3 or 4 of those factors, intermediate 2 of those factors, and unfavorable 1 or fewer of those 4 lifestyle factors. What did they find? Look at this slide. Results among participants at high genetic risk. A favorable lifestyle in these 3 studies was associated with about a 50% lower risk of coronary events than unfavorable lifestyle. So all these people had high genetic risk, but those who followed a favorable lifestyle had about half the coronary events in these study populations as the ones who had unfavorable lifestyles. Among participants in the bioimage study, where they looked at coronary calcium, they found that both lifestyle and genetics play a role in how much coronary artery calcium you have. This is a very busy slide, but it highlights the fact that regardless of genetic risk, that is low, intermediate, or high, the biggest protective effect goes from going from an unfavorable lifestyle to one that was considered at least intermediate, as you see here. So the take-home message here is number 1, if you pick the wrong parents, bad genes can double the risk of cardiovascular disease, but a favorable lifestyle cuts it in half. An unfavorable or unhealthy lifestyle erases about half the benefits of good genetics. The take-home message, however, is the deadliest combination is this. If you pick the wrong parents, you got early premature coronary disease in the family, and you got an unhealthy lifestyle, your risk increases 4-fold of acute coronary events. And lastly, this recent blockbuster study looked at healthy lifestyle factors on population life expectancy. They emphasized that Americans have a shorter life expectancy compared to almost all other high-income countries. They looked specifically, in this case, at 5 low-risk lifestyle factors. Not smoking, normal BMI, at least 30 minutes of moderate intensity physical activity most days of the week, moderate alcohol consumption, and a healthy diet score. They looked at this on premature mortality and life expectancy. Look at these data. Over a 34-year follow-up, Those who had all 5 healthy lifestyle factors could prolong life at the age of 50 by 14 and 12 years for women and men respectively. Those who were in the most active cohorts of that population lived on average 7 to 8 years longer. Here you can clearly see gained life expectancy by applying healthy lifestyles compared to no healthy lifestyles. Once again, women gained 14 years, men gained about 12 years by adopting extremely healthy lifestyle practices. Their take-home message was this: Americans could narrow life expectancy gap between the U.S. and other countries by adopting healthier lifestyles. Prevention should be a top priority for national health care policy. Preventive health care should be an indispensable part of the U.S. healthcare system. My own bias is this: if you're a physician, you're a primary care physician, too much emphasis has been placed on you as opposed to the patient. The future is suggesting that we need to change that and put more responsibility on the part of the patient, not you who see 600 to 800 or 1,000 patients per year, 10 minutes a patient. In essence, then, healthcare insurance policies are increasingly saying, if you get an annual physical, if you maintain your risk factors, you're going to pay lower premiums than the person who lets these things get away. To conclude, what I want to leave you with. This shows the evolutionary treatment of cardiovascular disease. In the 1960s, we said it was lifestyle. Then in the 70s, we had the answer. They said it was bypass surgery. Bypass surgery would take care of heart disease. Then we had pharmacotherapeutic advances. Then came along angioplasty. I see patients on a regular basis, terrible, who've had 5, 6, 10, 12 angioplasties. Unconscionable. It's not doing the job. Thrombolytics, interventional devices, I believe the hottest area in cardiology right now is preventive cardiology, combining lifestyle change with appropriate pharmacotherapies. As one who studies populations who live long, healthy lives, I learned a great deal from this article, that you see, Secrets of Living Longer, published in National Geographic, where they went around the world and studied populations who routinely lived to be 90s, 100s, 110. What are the common characteristics? There's 5. Number 1, all don't smoke. As I emphasized earlier, smoking on average decreases the lifespan by 10 to 12 years. Number 2, put family first. Been arguing with my wife for years, who said family should come before work and everything else. I came to the sobering realization my wife has been right all these years. You live longer if family is a higher priority. Number 3, be physically active every day. Number 4, keep socially engaged. And number 5, there are people who eat lots of fruits, veggies, and whole grains. So you notice I didn't mention aspirin, statins, beta blockers. They don't smoke, they put family first, they're physically active every day, they're socially engaged, and they eat lots of fruits, veggies, and whole grains. In fact, I agree with the American Heart Association, who says, when people say, when I got a patient who's had a heart attack and says, give me one thing that I need to follow, diet-wise, my answer is very simple. I want you to eat 7 to 8 servings of fruits and veggies every day, and don't leave the damn breakfast table unless you've had 2 servings. So this morning, I had oatmeal with blueberries, I had a small glass of V8 vegetable juice, and I had an apple before I left. There's 3 of the 8. It's not that hard. Get out of the gate fast, and have your patients get out of the gate fast by loading up on fruits and veggies first meal of the day. To wrap this up, I read this article, New England Journal of Medicine 2012, that I think summed it up all. Moving from our reactive sick care model to proactive health care. And they concluded, and this is so true, health care will soon account for $1 out of every $5 spent in the U.S. We're currently at about 18% of the GDP is spent on health care. If these trends continued, health care will become unaffordable unless we find effective ways to implement prevention programs. In closing, we need to go beyond acute and palliative care. Contemporary healthcare providers need to become champions of achieving healthy lifestyle overhauls in the patients we serve, well beyond the acute and palliative care we provide in emergency centers, cath labs, operating rooms, physician offices. The paradigm shift needs to move from not only helping people when they're ill, injured, or sick, but to helping people help themselves 24 hours. That should be the future of healthcare. If we can do that, many of the best years should be yet to come. Thank you very much.
That concludes another in a continuing series of programs on medical malpractice, risk management, healthcare law, practice management, and selected clinical topics. Presenting was Dr. Barry A. Franklin.